Hi, this is Brian Kim. I want to share with you how to achieve a well-centered and sized rhexis performing manual capsulorhexis technique. And so it's been a while since I've shown a capsulorhexis video, and so I'm going to review some basic principles and some concepts with regards to helping you achieve a well-centered and sized rhexis. So the first things first, there is no single way to make a perfect rhexis. Everyone has a different style. Everyone has a slightly different technique. And so this is not about trying to reproduce someone else's technique. This is more about principles. And so again, everyone uses a different technique because they also use different forceps. And so based on the way you're trained, and you might try different types of instruments, and there's probably hundreds or thousands of different forceps. This is not about using a specific forcep. Rhexis behaves differently with different types of OVD, and so this is very important. You cannot cookie cutter your technique because every OVD will cause the rhexis technique to be different. And finally, this is about basic principles that you need to follow to achieve a well-centered and sized rhexis. Again, you really can't cookbook capsulorhexis. You can't follow someone's technique, and if you're using a different forcep or different OVD. So these are the rhexis rules. Keep the anterior chamber as filled as much as possible. By keeping the chamber filled, you're flattening the anterior capsule, and you want to be mindful of when you're doing the maneuvers that you're not having too much OVD egress. Number two, you want to start the flap only after you've achieved the proper rhexis radius. In other words, as you're pulling the tear and then you start the flap, you need to make sure that the flap radius is correct. Otherwise, you're going to have a too small or a too large rhexis size. You want to pull the flap as flat to iris as possible. In other words, you don't want to pull up towards the cornea as you're making the rhexis. You want to stay flat and parallel to the iris plane as possible in order to get a well-controlled rhexis flap. And finally, as you pull the flap, you must constantly redirect the forces towards the center. And this is also in conjunction with following the corneal mark. As long as you follow the corneal mark and you pull the forceps towards the center, because as you're rotating, you have to maintain a centripetal direction of the force in order to prevent it from going out. If you pull the forceps too peripheral, the tear is going to go out. If you pull the forceps too much towards the center, the tear is going to go inward. And so it's a fine balance between pulling it peripherally, pulling it centrally, but you have to maintain that same directionality as you're going around. And that means as you're pulling it, the direction towards the center should be fairly constant. However, as long as OVD is starting to egress, you have to pull towards the center even more, or you can put more viscoelastic in the anterior chamber, and then you'll be able to redirect the forces as you normally do. Okay, so let's look at a case example. I use my corneal mark to make my rhexis mark, and then I push OVD after I make my incision. And so that's important. After you make your incision, you can have OVD egress. And so I like to add a dollop of OVD after I make my incision. And I've made this case into half speed. And so this is going to be very slow, but this gives me some time to talk about what we're going to do. And so going slow is fine because you'll be able to see what I'm trying to achieve here. So number one, I'm going to use a puncture style technique. Everyone has a different technique. The technique is not so important. You can use a cystotome, you can use a forcep. It doesn't really matter. The point is when you pull on the tear, you need to make the tear about the radius of the rhexis. So once you pull it, you want to pull it to the point where you are comfortable where the radius of your rhexis is going to be. And once you achieve it, then you begin to pull the flap. Once you've pulled the flap, you've essentially created the radius of your rhexis. And so once you start pulling, you want to go around circumferentially. You want to make sure you're fairly flat to iris plane. And as you pull, you see I'm actually pulling towards the center as it's going around. And so that's very, very important. Grasp the flap. As you go around, you want to redirect slowly towards the center, towards the center, towards the center. And you're watching at the same time the direction of the tear as it's going around. You're wanting to make sure it's following the corneal mark. If it's going too peripheral, you got to pull more central. If it's going inward too much, that means you're pulling inward too much. You have to pull more peripherally. And so it's a balance between how much should I pull peripherally, how much should I pull centrally. I'm staying flat to the iris plane the entire time. I'm making sure there's not much OVD egress, which will change the forces and the dynamics of how I'm doing my rhexis. And once you're done, you pull the flap out and then remove the viscoelastic from the anterior chamber. And if you've done all those things, at the end of the case, you should have a fairly well-centered and sized rhexis. Again, you want to puncture, make sure the radius is about where you want it to be before you begin the flap. Make sure you stay flat to the iris plane as you go around. As you pull the flap, you're not only pulling in one direction, you're pulling constantly towards the center as you do the rhexis. So again, this is case number 2. I use a corneal marker to help me center and size the rhexis. After I make my incision, since viscoelastic can come out, I push OVD to flatten the anterior capsule. I'm going in with my forceps, and you want to make sure that the teeth are pointed down. If your forceps are not oriented straight up and down, you're going to gape the incision and cause more OVD to come out. So again, I puncture the center, and with the teeth closed, I'm pulling downward towards me. Once I reach kind of the radius that I want to achieve for my rhexis, I grasp the edge of the flap here. And you see I'm grabbing and grabbing and grabbing. That's allowing me to extend the rhexis just minutely to the point where I want it to be. And then I finally grasp and I start to pull. As I pull, you want to keep redirecting the forces towards the center. You see how I'm pulling towards the center. I'm pulling peripherally, pulling centrally. You're constantly redirecting. And what is the endpoint that you're achieving? You're trying to make sure that the rhexis flap is following the corneal mark. And so that's what you're doing. You're staying flat and you're pulling centrally, peripherally, centrally. You're constantly modifying the direction of the flap, and that is based upon the corneal mark that I've made. And so I'm pulling as I go, I'm pulling, but again, I'm watching the corneal mark. If I'm going to peripheral, I'm pulling more central. If it's going too central, the flap, I'm pulling more peripherally. It's unlikely that the flap pulls centrally, and so more likely the flap continues to pull peripherally, and so you have to be mindful of constantly pulling towards the center whenever necessary. And at the end, I finish the flap, burp viscoelastic out. And so this is the end of the case. I remove the INA tip and I push BSS and then hydrate my incision. So again, you can see there's a well-centered and sized rhexis for this case, again, following those same principles. So this is case number 3. Again, I use a corneal marker, which will help me center and size my rhexis. After I make my incision, because viscoelastic can come out, I push more viscoelastic, which will flatten the anterior capsule. Having a flat anterior capsule will give me better control for my rhexis. As I go in with the forceps, I go in sideways. But then once I go in, I make sure I point the tip down. And that's because since the forceps open side to side, you want to make sure that the forceps are pointing down. Otherwise, I will have gaping of the incision, which will cause even more OVD to come out. Again, this is a puncture style rhexis. I puncture the center and I'm pulling towards me, creating the tear. With the teeth closed, I keep pushing on the tear, which will slowly create little by little a larger tear. Once I reach the proper radius of the rhexis that I want to have, I grasp the edge of the tear to create the flap. I'm going around circumferentially. As I grab, I make sure the rhexis is following the corneal mark. If it tends to go wider than that, I have to pull more centrally. Otherwise, the tear is going to extend and go outside of the corneal mark that I made. I grab every few clock hours, pulling, following the corneal mark. Again, as I go around, I want to pull centrally as I go. The entire time I'm staying flat to the iris plane. I'm not lifting up. Again, the teeth of the forceps are constantly pointed up and down. I'm not torquing my forceps, which will gape the incision. I'm repeating the same maneuvers over and over again. Again, you want to make sure you follow the corneal mark. If you are going too far away with the flap peripherally, you have to pull more centrally. Again, during the entire time, you're staying flat to the iris plane. And then at the end, I'm finished the rhexis off, burp the viscoelastic out, and this is the end of the case. I'm filling up the eye and hydrating the incisions. And again, you can see there's a well-centered and sized rhexis. Again, by following these 4 basic principles, this is not a timed part of the surgery. You can take your time as much as possible and reposit as much OVD as needed. So I use a corneal mark, which will help me center and size the rhexis. After I make my incision, I push more OVD to flatten the anterior capsule. I go in with the teeth sideways, which will help reduce OVD egress. Once I go in, I rotate so that the tip is down so that the forceps open side to side, which will help reduce OVD egress during the rhexis. I puncture the center and I pull the tear towards me. Again, the tear will dictate the radius of the rhexis, very important. Once I reach the point where I've compared where my corneal mark is and where I want to make the size of the rhexis, I start the flap. Once I start the flap, this will dictate the size of the rhexis. I start to go around circumferentially, making sure I'm flat to the iris plane. As I'm pulling, I'm redirecting the forces towards the center because, again, the rhexis wants to go peripherally. I'm having to redirect towards the center, and I'm using the corneal mark to help guide me as far as how much I should pull towards the center in order to help achieve that well-centered and sized rhexis. I continue the same maneuver over and over again. Again, anytime during the case, if you feel like you have poor control, you can push more OVD into the anterior chamber to flatten the anterior capsule whenever possible during these maneuvers. And as I pull around, I finish off the rhexis, burp the viscoelastic out, and this is the end of the case. I hydrate my incisions. You can see this case had a slightly smaller size pupil, but nonetheless, the principles are the same. So again, number one, not all rhexis techniques are the same, and that's because everyone learns it differently, everyone uses a different forceps in their training, and everyone has different OVD. And so every OVD behaves differently. And so the same principles apply, but how you do it and how much you have to pull OVD, depending upon the type, you can have more or less egress, which means you have to have more or less aggressive pulling towards the center. And so that's the difference with the OVD. If you have an OVD that tends to come out, you have to be more aggressive with pulling towards the center. And you may have to put more OVD in as you go. Some OVD has really great flattening of the anterior capsule properties, and some others don't. And so you just have to modify your technique based upon the OVD you use. But the basic principles are the same. As I said, number one, keep the anterior chamber as filled as possible to flatten the anterior capsule. When you make your tear, whichever way you do it, a forceps or a cystotome, you want to create the tear, but as you create the tear, you are really actually creating the radius of the rhexis. And once you've achieved the appropriate radius of the rhexis, you grab and create the flap. As you create the flap, you've already created the radius of the rhexis, and you want to follow this radius all the way around, making sure you're consistent 360 degrees, but you want to make sure you're flat to the iris plane. And as you're pulling the flap, remember the rexus tends to want to go peripherally, so you have to constantly redirect your forces towards the center. How much you pull towards the center will be dictated upon what the rexus is doing. You're following the rexus, making sure it's within the corneal marks, and if it tends to go out, you want to pull more towards the center. Again, this will vary dependent upon your technique, dependent upon how much OVD egress you have, which will also be dictated by the type of OVD you are using. Some have more or less retentive properties. And after you've done this and you're staying flat to the iris plane the entire time, you should be able to achieve a well-centered and sized rexus. So again, I hope that these principles are helpful to you. Again, I'm sorry I don't have a magical formula as far as how you should do your rexus to get a perfectly centered and sized rexus. But again, if you follow these principles, you should be able to achieve a well-centered and sized rexus. So I hope this was helpful to you, and I thank you for your attention.